Okay, so for November's MEC Minute, I'd like to discuss the 2019 MEC EMS protocol. Really, my talk, I have three topics for today. One has to do with a quick review of the credentialing timeline. Hopefully everyone is aware that we do have a credentialing process in place that we started this year. The idea being that we're going to do it this second half of this year, and we'll continue to revise it and review it to see how we progress. But I think it's an important thing that we do in order to ensure that we provide the best quality care for our patients, which means we're going to verify everyone's knowledge base and skills, verify that people have the credentials that they say they have, and continue to move this forward. This is a process that has been coming up across the country, and compared to other states, Ohio is still a little lagging behind. So we're going to talk a little about the credentialing timeline in terms of what we have revised the timeline to for 2018, and this is based upon conversations I've had with the EMS coordinators in the past couple of weeks. I'd also like to review some of the 2019 changes to the protocol. Really, there are not a lot of them this year. It's probably the fewest number of changes we made to the protocol ever, but I'll go through the high points on that. And then we've added to the protocol a supplemental section on medications and procedures, and this is there as a reference for those providers who may be called upon to transfer a patient from a freestanding emergency department or from a freestanding surgery center to a hospital-based emergency department. There's some state position statements in place from the MFATS board that I think we need to comply with, and I'll talk more about that the last part of our discussion. So looking at the credentialing timeline, we have set this up so that we would like our providers to review 4 of the 6 MEC minutes for the last half of this year. We would like to have a protocol review or protocol assessment, and we're doing that now as part of this assessment. We are going to have a protocol assessment. I don't want to use the word test, but it's a protocol assessment to look at your knowledge base. It's open book. It'll be available in January. I'm encouraging everybody to do it as a group learning session through their crew when on duty. It's something you can sit around the table and go through, and then come to terms with what the answers are. Dr. Stoner, our associate medical director for pediatrics, and I in the next couple of weeks will sit down and record another video where we review the answers to the protocol assessment and give our rationale for the answers that we've chosen, and that will be distributed via the EMS coordinators for review after you've participated in the protocol assessment. And we would like the protocol assessment to be completed by the end of January. This way you have time to review the 2019 protocol and then participate in the assessment and complete the assessment by the end of January. And then I'm looking to the chiefs to verify everyone's credentials by February 15th, which is a Friday in mid-February. So that's kind of where we are with this credentialing timeline. I think we're a bit overly optimistic in terms of how we could get this accomplished by the end of the year. I think the timeline that I've just mentioned is more realistic. In terms of protocol changes, most of them are available on these 2 pages as a summary that are found on pages 305 and 306 in the protocol. You should have access to the 2019 protocol via your EMS coordinators. I distributed an electronic copy that can be printed a week and a half or 2 weeks ago. And on January 1st, the protocol will be updated, or the protocol app will be updated with the most recent document on your cell phone. So come the first of the year, or the first time you open the ResponseSoft app after the first of the year, you'll get a prompt to update the protocol. Please say yes. So some of the tweaks that we're looking at, there are a couple things we did. One was, there are studies out there that really say that epinephrine is of questionable significance for patients in cardiac arrest, and actually epinephrine has been negatively associated with survival to discharge from the hospital. In other words, if you're a patient in cardiac arrest and receive epinephrine as part of your resuscitative efforts, you are less likely to survive to hospital discharge. We've limited to epinephrine to 5 doses. After you've given 5 doses, you're done in terms of epinephrine. It doesn't mean you stop at that point, but you don't give any additional epinephrine. In terms of terminating resuscitation, you can make a decision at any point to terminate based upon the standard that we have in place. And that standard does not rely on the number of doses of epinephrine that you've given. If you have a patient in cardiac arrest, studies have shown that a humeral IO is better than a tibial IO. It's nice to do a tibial IO because you're away from the head and you're not interfering with anybody who's trying to get airway secured or defibrillate the patient. But studies do show that there is a delay in the medications given via the tibial route to getting into the central circulation versus the humeral route, and that's simply because the patient's in a low flow state and the leg is farther from the heart than the humeral head. We've also noticed that we had incorrect energy settings as the maximum energy setting for defibrillation, and for some reason it was 300 joules or 300 watt seconds. We found that as an error and we've corrected that, so the correct energy setting as a maximum is now 360 for the LifePak devices. We've also made some changes with succinylcholine and the RSI process. I think you've probably heard by now, but we're going to remove rocuronium from the protocol and substitute succinylcholine. We're doing this in order to comply with an MFAT's position statement on the use of RSI and paralytics, which encourages the use of short-term paralytics for intubation. Succinylcholine is the only short-term paralytic. We will be making this as a phase out through the first half of 2019, and then effective June 30th, 2019, rocuronium is no longer part of the protocol. So this gives us 6 months to use up any stocks of rocuronium we may have in our stations. We also added a statement to the RSI protocol that RSI is contraindicated if the patient has their own airway and is maintaining it adequately. And we've added a couple statements to the effect that RSI is indicated if the patient has a GCS of 8 or less, or if the patient has any evidence of inability to protect their airway. So if you think the patient's got a poor airway, then our suggestion is the patient be intubated using RSI. We have made some pharmacology changes. Most of these are relatively minor and probably won't affect you. The biggest one is rocuronium, which is off protocol June 30th. Vecuronium will no longer be listed as an alternate medication to rocuronium. We have had Phenergan listed as an alternate medication for Zofran for nausea and vomiting. Zofran intravenously has been associated with tissue necrosis if there's infiltration. It is a very caustic substance, and if there's infiltration into the soft tissue outside of the IV or outside of the vein, the patient's at high risk for tissue necrosis, and there are some patients who've required tissue grafting or skin grafting because of Phenergan extravasation from the IV. Many hospitals and healthcare systems are taking intravenous Phenergan off their formulary. I know Mount Carmel is doing that, and others are doing it as well. We've had Aplasol or tuberculin PPD as part of our med list in the past, and that's because some of our agencies did their own TB skin testing. Nobody is currently doing that. Almost all TB testing is now being done through occupational health vendors, so we've taken that off the medication list. I don't think that will really affect any of you as providers. We are replacing Phenergan with Compazine as an alternate to Zofran. Compazine is similar to Phenergan. It's a little bit less sedating, and it is much safer if there's extravasation. At the hospital, we use Compazine a lot for migraine headaches, but for you, you will not see it on your trucks unless we have another shortage of intravenous or oral Zofran. But Compazine's coming on the list, and you'll find it listed in the pharmacology section where we have our drug information sheets. We've made some changes to our clinical standards. I think most of them you're aware of. We have deleted Mount Carmel West as a trauma center, and I anticipate that once it formally closes, it'll come off the list as a destination hospital, and Grove City will go up as a destination hospital if there's any off chance that we're taking patients in that direction. At downtown, where Mount Carmel West is, there'll be a freestanding emergency department, and I really don't see that as something that we need to worry about in the future. I don't think we'll be taking any patients there. Mount Carmel East has been added as a level 2 trauma center. You're already aware of that. OSU East has been added as a level 3 trauma center. We've made that as a correction to the clinical standards because with our last revision of the protocol in July, August, it was not yet official that OSU East was designated as a trauma center. So OSU East is a level 3 trauma center. Keep in mind that they do not have the ability to care for any trauma patients who are pregnant, and they should not be receiving trauma patients with significant head injuries or any findings to suggest spinal cord injuries, since they do not have in-house neurosurgical coverage. They can take all other levels or all other types of trauma patients, and they have a very good orthopedic service there too. We've added to the clinical standards permission to transport patients to the freestanding psychiatric facilities as identified in the standard for freestanding psychiatric facilities. So keep those resources available. If you're unsure what resources are available for freestanding psychiatric facilities, let me know and I'll be glad to fill you in. Your chief has to be comfortable with you taking patients to a freestanding psychiatric facility, so verify with your chief that you should do this before you start taking patients there. And then we've made some revisions to stroke destinations as well. On this slide, I've got more detail regarding trauma care. So, level 1 and level 2 trauma centers, according to the American College of Surgeons Committee of Trauma, provide identical clinical care. So there is no reason that you should take a patient to a level 1 versus a level 2 facility. Clinical care is identical. Keep in mind, Nationwide Children's is a level 1 pediatric trauma facility, but they do not have any obstetrical capabilities. So if you have a pregnant female, regardless of age, they should not go to Nationwide Children's. So if you have a 14-year-old that's pregnant, they should go to the closest of the trauma centers that are the adult centers. All of the adult trauma centers have obstetrical capabilities. OSU East, again, is a level 3, but no obstetrics or TBI or spinal injuries. The last thing that's not really in the protocol, but it's just an editorial comment for me, is we have a good selection of trauma centers, and I would encourage you to avoid overloading any one trauma facility. And I really see OSU East as in a good position to help balance the load, particularly for patients who may be injured along the I-670 corridor. But that's a decision you're going to need to make on the street. But I'm not sure you're doing patients any favor if you take 3 or 4 victims from the same event to one hospital when you have other trauma facilities reasonably available in our community. So just keep that in mind. Stroke care, there's one addition that may take a little bit of work for all of you to get used to. Diley Ridge is now accredited as an acute stroke-ready hospital, which means they can take stroke patients who are LAMs 1 to 3 who've had stroke symptoms for less than 4.5 hours. They can rapidly perform a CT, they can administer intravenous thrombolytics, and they have a process in place to rapidly transfer stroke patients to a primary or comprehensive stroke hospital. The big focus on stroke care right now is early and quick administration of TPA or thrombolytics, and Diley has met the standard as an acute stroke-ready hospital. For most of us, I don't think geographically, Diley's in a good position to receive a lot of stroke patients from our current member EMS agencies, but it is a resource. We have added some additional definition in terms of stroke destination decisions to our transport clinical standard. And it really breaks down to what's the patient's LAM score and when were they last known well. I think you're all aware that in the past year, an increased focus has been placed on intervention with clot extraction for patients who have a clot in a reasonably approachable position. Patients who have a high LAM score or who have a last known well of greater than 4.5 hours but less than 24 hours should go to an interventional facility or a comprehensive stroke facility. So in trying to make these comments even simpler, if the patient is last known well less than 4.5 hours and they have a LAMS of 3 or less, take that patient to the closest stroke hospital, whether it's an acute stroke ready, primary, or comprehensive. Go to the closest facility. If the patient's last known well is less than 4.5 hours and they have a LAMS 4 or 5, we should transport those patients to the closest comprehensive stroke center, unless bypassing a primary stroke center or acute stroke ready hospital will add more than 15 minutes to the transport time. So if you can get to a primary stroke center in 10 minutes and a comprehensive stroke center in 20 minutes, your choice should be go to the comprehensive stroke center for those patients with LAMS 4 or 5 and last normal less than 4.5 hours. If you have a patient who's last known well more than 4.5 hours, and I left out 24 hours, but greater than 4.5 hours and less than 24 hours, those patients should be transported to a comprehensive stroke center, unless bypassing that primary stroke center will add more than 15 minutes to transport time. And again, the focus is quick imaging on these patients. When they are over 4.5 hours, they are not a candidate for thrombolytics, and the only potential procedure that may help them is clot extraction via a interventional radiologist or interventional neurologist. So anybody who is in this window of more than 5 and less than 24 hours should go to a comprehensive stroke facility. Probably the easiest example is the patient with the wake-up stroke. They went to bed at 11 o'clock. 7 o'clock, they're found by a family member with symptoms consistent with stroke. Well, those patients we don't know when their stroke occurred, so we assumed it's more than 4.5 hours, and they need to go to a comprehensive stroke facility so that they can be evaluated for a clot that may be amenable to clot extraction. For any patient who has last known well more than 24 hours, you can take them to any hospital, and they do not need to be a stroke center. The other comment I'd like to make is, we do have members of MEC EMS who geographically are far away from any of our comprehensive stroke centers, and I think prudent medical judgment is those patients for those agencies with stroke symptoms should go to the closest facility where they can be imaged, given TPA, and if necessary transferred into Columbus area for interventions if they're a candidate. So if Lancaster has an acute stroke patient, they should take their patients to Fairfield Medical Center. It's a primary stroke center. If we're talking about Heath or some of the other more central Licking County agencies, Licking Memorial Hospital is the more prudent receiving facility, unless you can get to a comprehensive or primary stroke center quickly. And that's a geographic decision you need to make in concert with your chief. Again, stroke destinations, any patients with a LAMS of 1 to 3, less known than 4.5, can go to any of the facilities that I have listed, which include OSU East as a primary stroke center and Diley Ridge as an acute stroke ready hospital. Grant Medical Center is also a primary stroke center, as is St. Anne's. Patients with a LAMS of 4 or 5 and last known well over 4.5 and less than 24 should go to the closest comprehensive center. And patients who have a LAMS of 1 to 3, patients with a last known well greater than 4.5, less than 24, or have a LAMS of 4 to 5 should go to comprehensive. It's all clear there. I just misspoke. And then any patient whose last known well was more than 24 hours, take to the closest hospital. They are really not a candidate for any stroke interventions. Here's just kind of a tale of two strokes, just for comparison to help give some illustration. The first patient on the left is a 70-year-old male, last normal 45 minutes ago. He's got right facial droop. He's able to move his right arm, but he has some drift, and he's got a grasp in the right hand, but it's weak. where should you take the patient? Should you take them to an acute stroke ready hospital with a 7-minute transport time, a primary stroke center with a 10-minute transport time, or the comprehensive center that's 15 minutes away? So contrast this patient to the next patient, who's a 70-year-old male who is, again, normal 45 minutes prior to arrival. He has right facial droop, his right arm is paralyzed, and he has no grip. Which hospital should you take the patient to? So think about both of those. Well, here's my answer. So the first patient had a LAMS of 3. And a patient with a LAMS of 3, less than 4.5 hours, should go to the closest stroke capable facility, and you have an acute stroke ready hospital 7 minutes away. That's where you go with the patient. The second patient has a LAMS of 5. This is a severe stroke. He most likely has large vessel occlusion and may have a clot that is suitable for extraction. This patient should go to a comprehensive stroke center. The incremental difference in transport time is 8 minutes from acute stroke ready versus comprehensive. That's well within that 15-minute interval that I mentioned earlier. So a patient LAMS 5 should be going to the comprehensive stroke center since it's relatively close. Some procedures that have been added or changed within our protocol. We have added a procedure that allows central line access, so that if you have a patient with a PICC line or a subclavian line or an internal jugular line or a Hickman catheter, you can access those catheters, those lines, if necessary during patient care. This does not include patients who have a subcutaneous port. Those are access points that are buried under the skin. You need to have special training and special needles to access those ports. We currently are not going to permit that per our protocol. I did not specifically cover dialysis catheters. From my perspective, and I think from most physicians in community, dialysis catheters should be left alone, should not be accessed unless the patient is in arrest or is about to die and you need immediate IV access. So if you have a patient who's in cardiac arrest and you feel you need to access a dialysis catheter, you can do that. If you have a routine transport and you would like to give the patient some medication for pain or nausea and vomiting, you should not access the dialysis catheters. We need to do everything we can to keep them from getting infected. Other things we've done with procedures is we removed the King LTD, and the iGel is now the supraglottic device of choice. We kept both in protocol for a couple years so that existing stock of King LTDs can either be used up or go out of date. We've reached the point where we are now fully utilizing the iGels, and the King LTD as of the first of the year are out of protocol and not covered. We also add a statement which is regarding the use of the iGel or supraglottic device and EMTs. It has been within the scope of practice for a number of years that EMTs may use these devices if the patient is in cardiopulmonary arrest. In other words, they're pulseless and apneic, an EMT may insert an iGel in order to ventilate the patient. I just felt it was important that we specifically state that in our protocol to allow them to do it if it's necessary. We've also added something at the end of the chapter, which is a new section, or end of the protocol, which is a new section on supplemental medications and procedures. We have it there because of expectations given by the MFATS board in their position statements on interfacility transfers. And these are medications and procedures that are not part of the protocol. They're not part of our drug license, but they're there as informational materials for EMS providers that may encounter or maybe request to transfer a patient from a freestanding ED or surgery center to a hospital-based emergency department. It will be available in response soft as a reference so that if you come across a patient with certain medication, you have some reference available. And we've tried to identify medications and procedures that we can reasonably anticipate you'll be asked or you may be exposed to and asked to transport a patient with. So I would suggest that you be familiar with clinical standards on interfacility transfers. If you have a facility or facilities in your community, or if you have a mutual aid agreement that may pull you into an area with one of these facilities. I know that, for instance, in Lancaster, FMC is building a new freestanding facility. I anticipate that Lancaster Fire will get most of the calls, but you never know if another agency may go in as a mutual aid company to transfer a patient. So you should be aware of this. Do have just a basic opening statement that says these medicines are medicines actually and procedures that you may be experienced or exposed to during facility transfers. So again, be aware of it. Just things that we tried to cover, thrombolytics and anticoagulants, cardiac drugs. Some of them you're probably used to. We've used to use IV nitro. We used to use IV dobutamine, dopamine. Those should not be any strange meds to you. Diltiazem is a med we use to control rate for atrial fibrillation patients, and metoprolol we sometimes use. It's a beta blocker and sometimes use it for rate control. Other medicines out there are insulin for diabetics, particularly if they are in DKA. Phenytoin and fosphenytoin, they're anti-epileptics, commonly used in patients who are in status epilepticus. Oxytocin, not oxycodone, oxytocin or Pitocin is used as part of delivery and used immediately after delivery to make the uterus shrink and stop vaginal bleeding. You may see that used in a freestanding if there's an unexpected delivery. Propofol we commonly use for ventilated patients. It must be on a pump. You can't adequately control the rate with a dial of flow or by eyeballing the drip chamber. And then antibiotics are also commonly used prior to patient transfer. There are a couple procedures that I'd like you to be aware of, blood transfusion and chest tube care. I will talk about that in a slide or two. Blood transfusions, the MFATS board is very specific. Paramedics may continue to infuse a unit of blood that has been hung at the sending facility, but you cannot hang any additional units. So they can't ask you to continue the current bag of blood and then hang a second one up when the first one is in. That's simply not permitted. Most common side effects of blood transfusion has to do with itching or fever. Sometimes people develop body aches. If this occurs, you should stop the transfusion immediately, and you can treat the patient with Benadryl for itching or rash. You can use Tylenol or ibuprofen for fever, aches, and pain. You should always document the bag number. Every unit of blood has a unique identifying number on it. That should be documented in your run report. And you should document what time did the transfusion stop, or when did the last bit of the blood infuse into the patient. You should document that time, and you should also document any potential side effects that the patient's experienced during the transfusion. I think it's highly unlikely that we're going to be asked to transport a patient with blood transfusion hanging, but the freestanding EDs do have a limited amount of blood available in their facilities, and as soon as I tell you that we're not going to have a case to do it, somebody's going to get a run and there's a unit of blood hanging. So be aware of this. Chest tubes, sometimes patients present and we need a chest tube. Sometimes we'll be called upon to transport the patient. We have a procedure in place. Some chest tubes are hooked up to water seal suction and maybe suction. The water seal kind of helps maintain the negative pressure within the pleural cavity. Sometimes when the chest tube is inserted, the collection container, the water seal device is hooked up to wall suction. Sometimes it's not. If you have a patient with a chest tube that's newly inserted and you're being asked to transport them, you should ask the provider if the patient requires suction during transport. Typically, you just have to plug the container into your suction, your wall suction, and it'll function fine. But ask first. Some chest tubes, particularly the smaller ones that we use for uncomplicated pneumothorax, have just a simple Heimlich valve. It's a skinnier tube, skinnier chest tube, and it's hooked up to a Heimlich valve via a IV tubing. I've got a picture of what it may look like at the bottom of this slide. You may see those as well. And if they do have this in place, generally all you have to do is just transport the patient. These patients do not require any suction. Chest tube patients may require fentanyl or other medications for pain or control of anxiety, so keep that in mind. Antibiotics, just a quickie. They basically have generic information available. Most common side effects of antibiotics that you're going to experience have to do with allergic reaction, and if you see any symptoms suggesting allergic reaction, you should immediately stop the antibiotic and then treat per our allergic reaction protocol. I've just got to have a few other comments regarding interfacility transfer. It is perfectly within your purview to ask for a nurse to accompany during patient transport, particularly if the patient has equipment in place that you have no experience in managing, or you are not comfortable managing. If a patient has anything like that, then you should ask for a nurse to accompany you. No one should expect you to transport a patient with therapy in place that you're not comfortable providing. Another thing to keep in mind is private ALS vehicles such as Connection or Medcare, the ALS but not mobile ICU trucks. They are regulated by the same scope of practice in Ohio as you. Sometimes we get called because a mobile ICU is not available, and we are seen as a mobile ICU surrogate. Well, that's incorrect. If they can ask us to transport a patient with our ALS capabilities, a private service ALS truck should be just as capable. And in addition, some ALS protocol items may actually be in place that allow the private service ALS vehicles to transport patients with medications that we currently don't have in our protocol. So there are some times when an ALS vehicle from a private company may be in a better position to transport some of these patients than we are, simply because the crews have some additional training or on items in their protocol that we don't have in our protocol. Another final comment is, ask if things can be adjusted for the transport. An easy example is, can drips be discontinued? So if the patient is on intubated, is on propofol, it's really not appropriate for us to try to transport a patient on propofol, particularly if we don't have a IV infusion pump available. Can they stop the propofol and sedate the patient with a big dose of Dilaudid or morphine plus midazolam, and then we give additional narcotics and sedatives during transport? Another example might be a patient who's diabetic and is on an IV insulin infusion. I would suggest that we're likely to have problems trying to maintain an infusion at a couple cc's an hour versus just giving the patient a couple extra units of insulin, turning off the insulin infusion, maintaining IV fluids, and transporting the patient that way. So I think if you're in those circumstances where you're looking at drips, ask if there's some way to get around them, if they can be temporarily discontinued during transport, or if you can delay the transport for 5 or 10 minutes until the infusion is complete. Those are something to think about. So that's all I have. I think I've covered all the points that are appropriate and pertinent to the 2019 protocol. If you have any questions, again, please send me an email or post a question on Workplace. Thank you.